of tuberculosis and chest diseases, which is being held in Agra. And today I'm really privileged to have with me a really well-known personality, and I welcome Professor Dr. Surya Kant,
जी sure.
who wears too many caps. He's chairman of the scientific committee of NATCON and head of Department of Respiratory Medicine at India's prestigious King George's Medical University. He is also chairman of UP Task Force and North Zone Task Force of National TB Elimination Program of the Government of India. Professor Suryakant is among the few doyens of respiratory medicine who have been the national president of all three important national professional associations of chest diseases experts. That is the National College of Chest Physicians, Indian Chest Society, and Indian College of Allergy, Asthma and Applied Immunology. Welcome, Dr. Suryakant.
Yeah, thank you, Shobhaji. You have done a lot of groundwork. I think everything you have searched for me. So thank you very much for kind word and
Yes,
introduction.
people do
Yeah,
need to know about the
yeah,
exemplary work you are doing.
yeah,
Doctor, with only 35 months left to
yeah,
end TB in India,
yeah,
because we have the goal of eliminating it by 2025,
yeah,
what, according to you, needs to be done more and urgently by way of prevention, diagnosis, and treatment?
yeah. Actually, this very ambitious target by our Honorable Prime Minister of India, Shri Modi ji, it was declared on 13th March 2018 at Vigyan Bhavan, Delhi, that is called An TB Delhi Summit, and in presence of Director General of WHO. And I'm fortunate enough that I was present in that meeting in Vigyan Bhavan on 13th March 2018. At that time, it was considered as almost impossible. Later on, the initiative took by the government of India, they were very much fantastic. But the only rider which I could see in the last 3 years is very important rider, that is COVID-19. Actually, COVID-19 has come up as a very important rider, not only in this country but throughout the globe, for the not only TB elimination program, for the all health ailments. So all diseases, maybe communicable, maybe non-communicable, every diseases have been affected during this time. So this was the real setback for us and for this ambitious target for 2020-25 to NTB. And now I can see for treatment, yes, treatment is free of cost in India. Diagnosis is free of cost in India. And to add on, government is also giving 500 rupees, Indian rupees per month as a nutrition support. So I think the treatment part, diagnosis part, they have resumed in 2021 and mainly in 2022. So now we have reached again in 2019, means pre-COVID era, as far as our diagnostic capability is concerned, our treatment part is concerned. Now, you see there are this is incidence of TB cases is in India is 27 lakhs per year, and this almost 27% share, global share, I would say, because if you see globally there are 100 million cases, so uh, 10 million cases, sorry, and if you see that our target was in 2025 the 27 lakhs, but we can achieve only 24 lakhs. So still we are behind the target in terms of diagnosis, but I have reached more than 90% of the diagnostic efficacy. For the treatment, if you see the treatment outcome is roughly around between 60 to 70%. So this is acceptable treatment outcome as far as the international norms are considered. Now the real challenge which I will discuss is the prevention.
Right.
Now, if you see, if any program does not see what are the risk factor for the tuberculosis, you cannot prevent. Now, what are the risk factor? What are the vulnerable groups in the society who are having more risk, or they are highly vulnerable society or sub-segment of the society for developing tuberculosis? Number one issue is nutrition. So undernutrition or malnutrition is the real challenge. It has been seen that tuberculosis is more common in those who are having malnutrition. Now, if you see in India, you see tuberculosis or the malnutrition in children, it's a real issue. Malnutrition in females, especially the pregnant females, is also issue. And there is a gender bias as far as nutrition is concerned. In an Indian traditional family, if you have some nutritional food inside the house, the government says the priority should be for child and mother. But you see, the Indian concept is जो कमाएगा वो पहले खाएगा, means the earner of the family, the head of the family, they are the on priority as far as the nutrition. Suppose fruits are coming in the house and they are limited fruits, so fruits will be given to the children, to the elderly, and to the earning member of the family. And females are always left. So there is always gender bias as far as the nutritional diet is concerned. And that's why you see in India, the 50% of the pregnant female, they are anemic. So this is the real challenge. So nutrition is a problem. Poverty is a problem. Still, if you see the 20 crore people, around, sorry, 30% of the population, 20, 30, between 20 to 30% of the population, this is under the poverty line. And so poverty is factor, malnutrition is a factor, and if you see there's a lot of issues related with females, I will specifically mention. Nobody is mentioning. I have analyzed what are the special issues with the females. As Shobhaji, you are representing the women power also as a interviewer. So I would say early pregnancy is the real challenge. It has been documented in the literature that those females who are having early marriage and early pregnancy, they are more vulnerable for developing tuberculosis. Number two, the shorter interval between two pregnancies. This is another factor. The lady is not compatible with the pregnancy, and with the interval of 1 year again she is pregnant. So that is the interval between two pregnancies. Third is the more pregnancies. So these are the three factors. Other than the general factor means the gender bias of the nutrition, undernutrition, malnutrition, etc. These are the female specific, of course, risk factor for the developing tuberculosis. Now coming to the very important air pollution. You see, latest report says that out of the top 50 most polluted cities of the world, 30 are from India. So air pollution is a big factor. Air pollution has got 2 to 3 times. Air pollution has got 2 to 3 times risk for developing tuberculosis. Smoking is also a factor. Smoking, I would say the first hand is smoking means active smoking. The second hand is smoking or passive smoking. The third hand is smoking, that is an environmental tobacco smoke. All three components of smoking, they are really challenge for us. In this country, there are 12 crore smokers. Approximately 12 crores are smokers, and similar amount or even double amount they are passive smokers. And passive smoking is as harmful as active smoking. We have done a study in King George Medical University in our department that smoking has got odds ratio of 2.5 for developing pulmonary tuberculosis. Means 2.5 times they are more vulnerable for developing tuberculosis in comparison to the non-smokers. So smoking is also a factor. Then comes the India's real challenge, another challenge, the crowding. We are the most populous. I think within few months we will cross the China also in terms of population. Roughly there are 140 crore population right now, and we will cross the China's number also in few months. So the biggest more population, and that is true with the congested population. And it has been seen by research, this is the evidence base, that the slum areas or the areas where no facility for proper ventilation and proper light, there is more risk for developing tuberculosis. Why? Because if there is no ventilation, we are not, means people are not getting fresh oxygen and fresh air, and light, it has been seen. You see, there is a very good handbook of tuberculosis written by Toman. When we were MD student, we were also reading the Toman, and still now my residents are also, students are also reading Toman. This Toman says that 5 minutes sunlight exposure kills the all tubercular bacilli, including the drug resistant bacilli. 5 minutes sunlight darkness. Now, assume the situation where sunlight is not entering in the houses. So again, there is a risk factor. Even the mycobacterium tuberculosis, the positive organism of tuberculosis, can survive into damp, less ventilated, and less light sunlight exposed area up to 10 months. So the if the bacteria will survive, they will continue to spread. So we need to awareness for these. We have to address these factors. And last but not the least, immunocompromised population. We are the now capital of the diabetes, we are the capital of heart diseases, so many diseases, and all are immunocompromised disease. Maybe diabetes HIV is less, of course, it is decreasing thanks to the all healthcare workers and government policy for that. The diabetes is increasing, hypertension increasing, heart disease increasing, lung disease, chronic lung disease are increasing, liver disease are increasing, renal disease are increasing, cancer is increasing. All are the immunocompromised people, and these people have, for example, diabetics. Diabetics have 4 to 8 times higher risk for developing tuberculosis. Now, in nutshell, and stress is also a factor. It's a evidence-based literature says that yes, stress can also lead to either activation of the old focus of tuberculosis or reinfection. So in nutshell, I can say that for addressing the problem of tuberculosis, you have to control pollution, you have to control smoking, you have to control the stress, you have to control the diabetes, hypertension, and all other immunocompromised states, and you have to address especially the social bias. A lot of bias, lot of social stigmas are still there. If a child developing tuberculosis in a family, no child play with him. No child of the family or relative sit with him. If a female developing tuberculosis in this country, even the females are being divorced. They are giving divorce. They are separated. They are not being taken care of properly. And still it has been seen as a gender bias that if lady is symptomatic, she is the last one to be carried out to the healthcare center and to be investigated. So I think prevention and these social issues, gender issues, they have to be addressed until you cannot have the target of NTB by 2025.
Exactly. Very well said.
Yeah.
The hard truth, but the
Yeah.
truth.
Yeah.
And so we have to take care of these factors if we
Yes.
really want to NTB.
Yeah.
Forget about 2025, even by 2030.
Yeah.
So these are the factors we have to take care of.
Yeah.
Even by way of that. So and also the preventive therapy. I do not know
Yeah.
how much it is being given for the TB preventive therapy.
Yeah.
What is the status of that?
Actually, tuberculosis preventive therapy, it is started way back in 60s, and the focus was the children. So it is practiced in this country, but it was never evaluated. And still it is a debatable issue. This is not the viewpoint of Dr. Suryakant, this is the viewpoint of all important leading pulmonologists of this country. A committee on TPT of the pulmonologists were formed from the Central TB Division under the National Task Force a mechanism of the TB elimination program, and I was the chairman of that committee. And I invited the 35 leading stalwarts pulmonologists of this country to give their viewpoint on the tuberculosis preventive therapy. I have already submitted the report, so I can disclose here also. Now it is in public domain. So out of the 35, 29 responded to this our letter which we sent for their viewpoint, and out of 29, 22 were against TBT, only 7 were in favor. So now you can see what is the current scenario of understanding and the advocacy of tuberculosis preventive therapy, because so many people argued so many things. uh, how will you rule out perfectly by simple chest x-ray? It is very difficult to rule out the tumor because efficacy, the effectiveness of the x-ray is only 50%. Only 50% cases may remain undiagnosed. And the second thing is that chest x-ray is not helpful for ruling out the extrapulmonary tuberculosis. It is helpful only pulmonary. So you are ruling out only pulmonary tuberculosis, not extrapulmonary tuberculosis. So this is the big question raised by the pulmonologists of India. Second thing is there is no anti-tubercular drug in the world which is working against the dormant population of the Mycobacterium tuberculosis. Means in the actually in latent TB, there is a main problem is that bacilli in dormant position, and in dormant state, no anti-tubercular drug is working. So query is there, debate is there. This debate is going on. So you see, for prevention, it is one of the policy. It is not only policy. It is being hyped that this is the only policy. No, I'm not agree. For prevention, it is one of the policy. If you are not addressing nutrition, only TPT will not work. If you are not addressing diabetes and other immunocompromises, TPT will not work. If you are not addressing the smoking problem in this country, TPT only will not work. If you are not addressing the problem of gender bias, social bias, and so many other things, under malnutrition, of course, they all are methods of prevention. So TPT is one of the method of prevention. How effective is, I mean, this is controversial thing.
Okay, even diagnosis, again,
Yeah,
drug-resistant tuberculosis
yeah,
is a huge problem.
yeah,
Are we testing upfront for resistance, having
yeah,
the molecular test facility now?
yeah.
Are we testing upfront all the
Yes,
things?
we are testing upfront
Mm,
because for any TB presentive case, maybe pulmonary, maybe extrapulmonary, the
mm,
sample is being processed for the CBNet or TrueNet. CBNet is also molecular based test, and TrueNet is our indigenous test developed in India,
mm,
so
mm,
cheaper also but equally effective.
mm,
And now Government of India has replaced that, only TrueNet will be purchased and supplied. So both tests are equally effective. The advantage of TrueNet is that it can, you can, this is battery operated also, so
yes.
you can use in the PSC villages, etc. Also, no specific air condition setup is required. You anywhere you can use, and only 2 hours training is enough to run this machine. So molecular tests are free of cost in all healthcare facilities, and we have got enough number of the CBNet and TrueNet machines.
Regarding treatment of
Ji.
drug-resistant
Yeah,
tuberculosis,
yeah,
there are new short regimens which have
yeah,
come up.
yeah,
Uh, when are we going to roll them out, or what is the situation there?
yeah. So thank you for asking the question, because our Department of Respiratory Medicine at King George Medical University is pioneer, and also the Center for Indian Council of Medical Research is study going on for the shorter regimen. I think you are talking of BPAL
Bipal,
regimen.
yes.
So we are the one of the center. I'm the principal investigator for that. And we have already, you see, started the bedaquiline based regimen, the Delamed and Bessie regimen also started using Delamed in the pediatric population also. And we are, this trial is going on under the banner of Indian Council of Medical Research, and this BPAL regimen, which has got 3 drugs components. And this is a very important hope, I would say. And I think the patient recruitment has been completed in many centers of the country, including my center. And the next phase is the analysis, follow up and analysis of the data. The time will tell probably how effective it is. And a few were concerned that maybe some toxicity, some adverse effect. So everything will be analyzed, and then only I will be able to comment that what the status of this short-term regimen of
How much time do you
BPAL.
expect that to
I
take?
think in 2025,
Okay.
before 2024, it's a very difficult. Maybe
Okay. Hmm.
it can come, the result can come. Publication, you see, because the follow up is also important. So unless we do follow up, how can we share the result?
Yes.
But anyway, preliminary result can be shared in 2024, early
Okay. Okay.
2024.
Yes, we have to be realistic
Yeah,
also
yeah,
about this.
yeah,
We also have news about
yeah,
new TB vaccines
yeah,
in the
Ji.
on the pipeline, and some results are to be announced by
Yeah,
end of March or early April.
yeah.
Now that brings us to the question of uh, vaccine hesitancy. You have spoken so eloquently about vaccine hesitancy of
Yeah,
COVID-19
yeah,
vaccine. We also have that current BCG vaccine for infants,
yeah,
and its uptake, if I remember correctly, 1980, it's a 100-year-old
yeah,
vaccine.
yeah, yeah.
From in the 1980s, it was 4%. Currently, I think it's 90%.
Yeah.
So, why did it take so long? You have such a vast experience of working in this field. What prevented its uptake, and why did it take so long? And even now, it's 90%. Is that's the only vaccine we have as of now
Yeah.
in TB? So, what are your thoughts on that?
Uh, you see, there are 3 issues regarding the vaccination. First thing is that trial for the new vaccine development are going on for about 100 vaccines.
Mm.
I think TB is the only disease where 100 vaccines are in pipeline for the development. Number one. Number two, there is also efforts are going on at 6, 7 trials, by 6, 7 trials, to modify this old 100-year-old vaccine, BCG vaccine. It was invented in 1921, and of course 100 years have lapsed. The actually efficacy of this vaccine, the BCG existing BCG vaccine, is from 0 to 80%. So vast difference in the literature.
Mm.
However, it has been effectively said that it basically protects from the severity of the disease
Yes.
and mortality.
Yes.
So that's why it is the Indian
Right.
National Health Program, and the first day, first vaccine is to be given for infant is the BCG vaccine. The third thing which you have, which I want to comment, is that is the revaccination of BCG. Now the government is planning, because what happened with BCG vaccination, there is a waning effect in due course of time. and it is set around, if suppose the child was vaccinated on the first day, so after 18-20 years of the age, means childhood, okay, protecting, adolescent age, it's protecting, but after the age of 20 years, there's a significant banning. So now the people are saying that this infant vaccination should also be used as a revaccination in the adults. So this policy government is, there is a lot of exercise, mental exercise, academic exercise, expert exercise is going on regarding can we roll out this adult vaccination as a revaccination for BCG. How effective it would be, because the BCG vaccination started way back in 60s in childhood vaccination, and I don't think there is a enough evidence that how effective it is. So, but this is proven that there is a waning effect. So, if we really want to reduce the mortality due to tuberculosis, then of course it's a good idea that till then we are not getting the new vaccine or the updated or modified BCG vaccine. We can use the same vaccine as a revaccination in the adult population. So, this is the
But
all
yes, but why did we take so long? Even the current BCG vaccine,
Yeah.
that should be 100%. Where was the vaccine hesitancy, or means any reason for that?
Yeah. Yes, definitely. I can foresee that whenever this revaccination in of the BCG vaccine will come for the adult, there will be a lot of hesitancy, because I have seen during the COVID times.
Yes.
You see, if you remember, on the first day when the COVID vaccination was launched on 16th January 2021, I was the first one in my state to get vaccinated. And that's why probably National Health Mission chosen me to make me brand ambassador for COVID vaccination program. Thank you, National Health Mission, for choosing me. And I then did a lot of advocacy, because there was a lot of hesitancy for the COVID vaccine, and there are a lot of myths which are being, of course, floated in the social media and whatnot, that this vaccine will do, this vaccine will do like this. Then I gave a statement in Hindi, vaccine ko chune, virus ko nahi. So this was a very prominent message for the people. So I think we have to prepare in anticipation that there would be the vaccine hesitancy. Definitely, the person will say, you see, there, because there's a BCG scar here on the left upper arm. So person will say, BCG vaccination? When I was born, the first vaccination I got this, see my scar. So I have the evidence that I have been vaccinated. Why you are giving the second vaccination? No, I will not take. How many vaccines I can take? I have taken already 3 vaccines of COVID. I'm taking influenza vaccine yearly. If the patient is respiratory, he will say I have taken pneumonia vaccine also. So many vaccines. How many vaccines you want? Vaccine is the cup of the tea of the children, not mine. So there can be a lot of questions, lot of query. I can foresee that it is not a difficult, it is not an easy task. It would be a difficult task for us and for motivating people for this vaccination. On the trial basis, I think early it should be done, and if it proves to be effective, then of course it can be taken under program condition.
So that preparedness has to start.
Yeah.
Because first of all, science
Sure.
takes
Yeah.
labor so much to
Yeah.
get some new vaccine or
Sure.
some new treatment out.
Yeah.
And then we take years to roll it out to the
Yes,
public.
definitely.
So would you say that definitely once the interim results are out, we should start preparing and we should start sending the right message to
Yeah,
the
preparedness will be started at least 3 months before to the rolling out with this vaccination, because first we have to eliminate this confusion that infant vaccination BCG is that, now we want adult vaccination. Why and how? So why the adult should be vaccinated, how they should be vaccinated, and we have to actually advocate. One point just came in my mind. When a 1 day child can be vaccinated with BCG, what is harm in adult? You are 30 years, 40 years, 50 years. What is the problem you get vaccinated? If the 1 day child can tolerate, so there is no problem, no side effect.
One day child
Yeah.
cannot protest, and that adult.
Yes, that is the problem. 1 day child cannot cry even.
Yes.
Yeah.
The
Rather, only can cry.
can only cry. Very right.
Yeah.
So, thank you very much. But
Yeah.
your message for the World TB Day,
Yeah.
we cannot leave you without that.
Yeah. You see, TB cannot be eliminated by a single person, maybe Prime Minister or maybe Dr. Suryakant or Shobaji or Bobby. Now, everybody has to be involved, because we should take the example of this polio. We eradicated polio in 2012 because of the mass involvement. So everyone has to be involved. Everyone from MP to PM, from Pradhan to Pradhan Mantri. Everyone has to be involved. Yes.
Many thanks, Dr. Suryakant. Friends, we were listening to Professor Dr. Suryakant, Chairman of the Scientific Committee of the 77th National Conference of Tuberculosis and Chest Diseases, which just ended today in Agra. Thank you very much.